All right, greetings, environmental epidemiology and risk assessment students. Welcome back. We're going to be covering a little bit on the coronaviruses today. And when I say coronaviruses, I'm saying it in a plural fashion because there are many coronaviruses. And I also want to emphasize that anything I say in here is not meant to be medical advice or anything like that. If you're sick or know people that are sick, always consult with a medical professional. We're going to be focusing in here on the epidemiology of coronaviruses, and we're going to start off on kind of the backstory or the history of coronaviruses as we know in the current scientific data. All right, so getting into this, we've got a few electron micrographs up here. One is a bovine coronavirus. This image from Dr. Linda Safe, one of the world experts on zoonotic coronaviruses. And then we also have this picture right here from the National Institute of Allergies and Infectious Diseases showing a different type of coronavirus. This one particularly infects humans, and this very well may be the SARS coronavirus too. We have a crown here that you might think of like a king or something like that. The word corona sometimes in certain languages may refer to something like a crown, and you can see how a crown has these spikes. And then the sun has a corona with these kind of spikes around it. This picture from NASA shows kind of the corona of the sun, and then human eyes also have a place that we call the corona in the anatomy of the eye. So that's where the coronaviruses get their name. So you can kind of see they have this like corona around the outside of them. And that corona is what also helps make them more easily attached or more specifically attached to their eventual host. Now, coronaviruses have been with us and among us for a really, really, really long time. Ever since there have probably been humans, there have probably been coronaviruses infecting us. Now, there are human-specific coronaviruses where we are the reservoir. And most coronaviruses, some may not cause us any problem. They've been around us for so long. But many of them, when they do cause illness, they cause a common cold-like condition. The disease condition might look like the common cold or be a cold-like condition. And there are other viruses that also do that. You may have seen these images floating around social media or the internet from this old American Medical Association encyclopedia saying, man, why are they making such a big deal about these coronaviruses? We've known about them for so long. Well, coronaviruses, just because they've been around us for a really, really long time, doesn't necessarily mean that they're all innocent in terms of are they likely to hurt us or not. So the one that is upon us has never been seen to our knowledge in human history. So this is a novel coronavirus, meaning that we have zero herd immunity. There may be some people that have had previous exposures that give them a little bit of a benefit, or exposures to other coronaviruses more recently that may give them some sort of immune benefit, but we don't know. We have a lot of unanswered questions. So by and large, we assume no herd immunity, meaning this disease can spread person to person. All persons could potentially be a host for this virus at some point. Now, other than coronaviruses, there are rhinoviruses that cause common cold-like symptoms. These actually are worldwide and almost occur year-round, the most common cause of upper respiratory infections. Like coronaviruses, they are RNA. Unlike coronaviruses, they do not have an envelope. The coronavirus has an envelope. All the coronaviruses have an envelope. Having an envelope means that washing our hands and practicing good hygiene, also some of our disinfection techniques, are more likely to work on an enveloped virus. So that's a good thing. Now, looking at the rhinoviruses, just this little excerpt of this comment from Clinical Microbiology Reviews, We've known about these for 60 plus years and been trying to find a cure for the cold, and we still haven't. So trying to cure RNA viruses as a whole group is something that's hard. Trying to do vaccines for an entire group of viruses like coronaviruses is hard. Trying to do a whole vaccine for all the influenzas is hard, and there's a reason for that. Now, I'll get into the promise or hope of cures and vaccines here shortly, but based upon our work as a scientific community, our success rate on vaccinations for viruses and for cures, although admirable and the best in our history, there are still, possibilities that these things won't work. So NPIs, or non-pharmaceutical interventions, in many cases, are one of our best ways of preventing the spread of RNA viruses person to person. Even with something, though, like the common cold, there are considerable economic burdens in terms of medical visits, lost school and work time. And this was published in Clinical Microbiology Reviews, including other non-influenza respiratory viruses. And it's important to note that there are different viruses out there, right? We have rhinoviruses, coronaviruses, influenza viruses, enteroviruses. Among the non-influenza related viruses, including the annual coronaviruses, viral respiratory illnesses cost us in the United States about $40 billion annually. That's in a normal year. The direct costs are about $17 billion per year. Indirect costs like lost time, lost productivity at work costs about $22.5 billion. The indirect costs are more than the actual medical cost. And that's for a typical year. And this does not include the flus. So when you include the annual influenza, this is probably substantially higher. And these numbers are not adjusted for the 2020 healthcare cost or inflation, because this was published in the Archives of Internal Medicine back in 2003. So getting a little bit more at the economic impacts of the infections and the diseases associated with these respiratory illnesses. Back in 1999, in an incredible journal, Emerging Infectious Diseases, it's just chock full of cool stuff. Professor Graybiel loves this journal. She keeps a subscription to it. The CDC is the home where this journal emerges, and it's a peer-reviewed publication, very science-rich. These CDC authors published this paper, The Economic Impact of Pandemic Influenza in the U.S., Priorities for Intervention. And they were kind of showing what would be the benefit of having vaccinations as well as other potential programs to prevent pandemic influenza. And the reason is because they kind of get at this with the quote that Ben Franklin says, which is, an ounce of prevention is worth a pound of cure. And you all may have heard me reference that before. The video I think I made as we were transitioning said that an ounce of prevention on this coronavirus epidemic or pandemic that's now upon us would have probably been worth tons in cure. Just that ounce of prevention would have gone so far. And we would be foolish to think that these types of events cannot happen again, because we know that the world that we live in is actually creating the right environmental cocktail to permit these things to happen more and more commonly into the future. Now, getting at what this paper says, I want you to know this paper first was published in 1999, so it's almost 21 years old, or it's 21 years old now. It assumed a higher case fatality proportion, or case fatality rate, as a lot of folks say. It had a much higher one, 314,000 hospitalizations, and almost about a third of them in this paper died. A little more than about a third, we'll just say. So it's a little different. I don't think a third of our hospitalizations with the coronavirus are going to die. But the hospitalization costs can be huge. We may have more than 314,000 to 734,000 hospitalizations over the course of this particular pandemic here in the United States. Hopefully, if we flatten the curve, they will happen over a longer period of time or maybe even years, rather than all at once. If we do not flatten the curve and they all happen at once, these numbers go out the window. So, this kind of assumes that we had the healthcare capacity and all those types of things to be able to treat these people in a situation that would be better than if everybody got sick all at once. And these numbers are not inflation adjusted for 2020. So if we were to adjust for inflation, we'd be looking at about 110, 111 billion to potentially 259 billion in today's dollars. But that assumes that healthcare inflation is similar. And it also assumes a younger population that existed in 1999 than exists in 2020, and a population with less comorbidities or less other illnesses that they might be living with. There's a lot of different factors that are at play. And there are so many factors where if these numbers get a lot higher or they happen all at once, we could see other indirect costs on the healthcare system from people who need typical medical treatment not being able to get it. So those are a lot of things to think about. So by and large, on the low end, I think we're looking at about $250 billion of cost just on the low end if everything were to be contained within this range. But that's just me spitballing. That's not probably the best approach. So there are people who are health economists that are working with epidemiologists to try to figure this stuff out. And opening up the economy is something that's an important question. When can we do it? How can we do it? I don't think it's foolish for any national leaders to be asking about that. We worry sometimes when people have an immune response, if their immune response is more harsh than the actual infection. We have those same questions that are happening in terms of the public health response. And those are absolutely great questions to be asking. But right now, based upon the preliminary evidence, it suggests that opening up the economy at this point in time could be far, far more worse than figuring out a better path and plan for the long term. Now, looking at the long term, there are some things that we hope may happen, but they very well may not. We know that viruses tend to have a certain seasonality. And the human coronaviruses definitely have a seasonality, typically not as common after April. The cold being very common from March all the way through October, but we also know that these viruses can also exist other times of the year. We also worry about what may happen in indoor environments. We know very little about this current coronavirus. If it has a seasonality, it might buy us some time, but it would be ignorant and foolish to pin our hopes on this. In my own initial kind of correlation analysis, thinking or hoping that the virus would not spread as quickly in warmer, more humid climates, when we adjust for income, it really loses, income and adjusts for the country because of underreporting, because of their income and their healthcare resources. Unfortunately, I didn't see humidity and temperature doing us much good, at least at this time of the year right now. So these are important things to think about. We know during the SARS epidemic, the first one in 2003, it definitely behaved more like that pattern that you see here. However, this disappearance of SARS, kind of getting into June, some folks believe it was through the strong public health campaigns and the interventions that were put into place. We only had about 6,000 cases in this WHO data. Some people estimate higher numbers for SARS, 7,000 to 8,000 cases. But overall, there was a certain degree of seasonality. So we know that there's seasonality in some cases for many of the coronaviruses. There may be seasonality for this particular one. But again, it would be foolish to think otherwise. What we also know from this, since I've got the slide up, and it was a coronavirus outbreak, we see a spike there, we see a spike there, we see a spike there. We might say this is almost trimodal. These spikes, or these kind of three epidemic curves, represent unique areas of the country and the world. Not so much the country. We didn't really have to deal with SARS too much here in the United States, but in Canada there were big problems. Hong Kong had problems. So we saw kind of an initial spike in Hong Kong. There were spikes in Canada and Hong Kong, all in this area. Sometimes they relaxed their public health measures and saw another spike. So we have a little we can learn from, actually a lot we can learn from the SARS outbreak on everything from a respiratory mask to kind of interventions that worked and didn't work, and also knowing that when we relax things too quickly, we can see resurgences. And that happened when we're looking at just 6,000 cases. Can you imagine when you start multiplying this 10, 20, 30-fold in terms of the number of cases? Because we're going to have far, far more cases. We already have far, far more cases than we had for SARS. There are some other interesting dynamics that may play out in society, and that would be the viral or virus-virus interactions that may also happen. We still have things like influenza and the common cold circulating in society. And there are some people that think that this thing, rhinoviruses, as they take off, they may somehow impact or influence the likelihood of disease spread for other things. So we don't know. These are interesting research questions that need to be asked. I mean, we were just looking at the impact of influenza and other viruses on the common cold just last year as a scientific community. These awesome authors here published this in an outstanding journal, PNAS, the Proceedings of the National Academy of Sciences. So again, a lot of research questions that can potentially be asked about things given the state of affairs. Now we're going to get into kind of a little bit about the coronaviruses here. I'll probably stop the video and get started on another video here in a few seconds. So I'll make a new video here real quick. And again, if you have any questions, you can always email them to me.